Hello and welcome back to the Intensive Care Society. I was going to say Critical Care Practitioner podcast then. I'm so used to saying that. This is the first time I've actually been in front of the camera. I'm joined by James Bruce, who works down in Torbay. And one of the reasons that he's joined me is because we want to talk about this. Now, if you can't see this on this camera, and I'm not sure whether you can or you can't, but this is the Critical Care Professional Development Framework for Allied Health Professionals that's been developed by the Intensive Care Society. Now, I chatted with Craig Brown, who was very much the driving force behind this, really, wasn't he, in getting this forward. But this is really about allowing those allied health professionals that are a very important part of the critical care team to have some support from the Intensive Care Society when it comes to their development. So, James, do you want to tell me a little bit more about it? What its objectives are, the work that's gone into it, and how those people out there that might be interested in it can actually access it.
Yep, I think this is a unique framework. This is the first time this has been done, trying to bring 4 AHP professions together. So within the same framework, we're looking at occupational therapists, physiotherapists, speech and language therapists, and dietitians working together with one framework. And what the idea is that it gives somebody who's an entry level therapist who's just come on to work on ICU, it gives them a framework to develop and flourish. And there's no actual ceiling. So it actually goes up to expert, which is kind of a national kind of pioneer in their field. And what the idea of this is an appraisal document, so you can use it with your team that you're working with, specifically in ICU. So you've got some kind of ideas to develop each year, and you can use this in conjunction with your trust IPR framework as well. The beauty of it as well is that you can use it even if you are a OT like myself who leads a team of dietitians and physiotherapists. So I can use that as a unique framework to add continuity throughout the whole team.
So it's very much about helping those allied health professionals.
Yep.
It gives them, because very much when they move into the intensive care department, it's then going to allow them to see their future within that department, isn't it? It's going to allow them to develop themselves very specifically towards those skills that are needed and almost to become specialised within that field.
Yep.
How long have you been working in the intensive care unit now?
Yep, so I was employed by Torbay 7 years ago with a remit of setting up a rehab service. At that time we had physiotherapists coming in and doing the acute chest management and the acute mobilisation, but there was no joined up service looking at kind of what actually happened to the patients when they went to the ward and how they kind of went to the community and bringing those patients back to follow up. We've had a follow-up clinic since the millennium really, where we only focused on the most acutely unwell patients when they are on the unit.
Right.
So it wasn't joined up. It was kind of first impact on the unit and then a follow-up service and nothing in between.
Okay.
So what we are finding with people who are coming back 3-4 months later with chronic conditions, which we really could have got services in to support that. And
so what kind of conditions are they coming back with?
So kind of patients that have, say they've come in with pneumonia, they go into the community, or they were going into the community with no joined up services, so they weren't getting kind of physiotherapy, they weren't getting services to help with their care, or they're completing their activities of daily living. Now what we're doing, we've got a goal-led service, so we set up goals on their ICU and on the ward, and when they go to the community, and we link in those community services to work on those set goals. So the patient has kind of a purposeful activity that they're kind of trying to strive towards.
Okay.
And what we tend to do with our team, we don't discharge them, we kind of phone them when they're home in the community just to make sure those services are linked in and make sure that somebody is following them up.
Yeah.
And what our team now is, because it's an integrated service, we will actually send therapists out to see them at home.
Okay.
So ICU therapists that they would have seen on the unit, we're seeing them at their home.
How do you justify that financially? Because measuring the impact of that is probably quite difficult, isn't it?
Yeah.
How does one do that?
So with our service is led by a really kind of dynamic matron, and our consultant body is really dynamic as well. And they know the outcome is going to be poor for these acutely unwell patients. So as a team, they invested in the therapy service. So my post, we've got a junior OT, we've got a rotational physio, we've got a assistant practitioner as well who does most of the rehab, and we've got a fitness instructor as well. All of those roles are employed by our ICU. So our service is ring fenced for those acutely unwell patients.
Right.
So we've got a bit more flex. And what we're doing as a service is we're taking functional outcomes at 4 parts of their journey. So at ICU discharge, at ward discharge, and at follow-up. And we also try to get some pre-admission baseline from the family. So we're looking at putting those into radar diagrams to see where we are. Are we hitting our pre-admission targets? And if we're not, if there's a discrepancy from pre-admission to follow-up, what can we do as a service to support that progression?
Okay, awesome. I mean, it sounds like a top service, and I know that occupational therapists are few and far between in intensive care.
Tiny amount.
These, absolutely, and you know, to me, they're as crucial as any other member of the team. And obviously, if we can, because just discharging from the intensive care unit isn't the end of the story. Discharging from a hospital isn't the end of the story. And getting them to home isn't the end of the story.
No.
And yet, often, I think a lot of our ITU patients, they leave hospital and they're under the care of the GP.
Yeah, absolutely.
And that's it.
And they haven't got a good idea about their journey and what's happened in that journey.
You know, they're not even reassured that actually they're going to take months and months and months and months and possibly years to get anywhere near back to where they were. And I would imagine that probably causes them a lot of distress because they think, well, I should be better by now.
Absolutely.
So a service like yours can probably provide that kind of reassurance and give them some realistic goals to work towards rather than I want to be the way I was before.
Absolutely.
Maybe I would, as a younger person, get back to how I was before. But
we've got every
as you age, I would imagine that's less and less likely. Right, we've gone off topic.
No worries.
This is what we're meant to be talking about.
Yeah.
This is fabulous. If you're an allied health professional, this is something you should seriously be looking at because it's going to give you the structure and it's going to give you the intensive care support to help you specialise in intensive care in whatever field you do normally already specialise in. So I think this is fabulous. I know Craig and the team have worked really hard for it, and it's a good basis on which to hang a lot of those skills, I think. Absolutely. Now, isn't it?
Please use it, and if there's feedback, please let us know. It will be available on the ICS website, so have a look. You can download it for free and try and use it, and email myself or Craig Brown or Gareth Coral, who's one of the physiotherapists. We're all on Twitter, so it's easy accessible.
Lovely.
Is that right?
Thanks, mate.
No worries.
Really good. Nice to meet you as well.
Cheers.
Thank you very much.
Bye.